All right. Good evening, all. My name is Ehsan, and I'm Surgical Neuro-Oncology Fellow at the Farhan University Hospital and member of Pakistan Society of Neuro-Oncology, PASNO. On behalf of PASNO, I welcome you all to this session. PASNO is organizing Neuro-Oncology webinar series, NOWs, and each session in this webinar series will be an hour long and held on alternate Saturdays. During the talk of our guest speaker, all attendees will be muted to enable the speaker to present without any interruption. Questions can be submitted in the chat box and will be answered once the presenter has finished their talk. Attendees can also raise their hands for questions. We will unmute them to speak. This session will be recorded and the link will be shared on the PASNO website. The speaker will take 30 minutes for topic presentation. And after that, there will be an open discussion between our esteemed speaker, panelists, and the attendees. The topic of today's session is pre-operative tumor embolization, and we are truly honored to have Dr. Farhan Siddiq with us today. Dr. Farhan Siddiq is an associate professor and residency program director of neurological surgery at the University of Missouri. Dr. Siddiq has the distinction of being board certified in both neurosurgery and neurology, having completed his training in the University of Minnesota and Thomas Jefferson University, respectively. He has special interest and active involvement in research related to cerebrovascular diseases, carotid diseases, acute stroke treatments, intracerebral hemorrhage, and neurotrauma. Thank you so much, Dr. Siddiq, for joining us today. The floor is yours, sir.
Thank you. Thank you for having me. This is a wonderful opportunity. Without any further ado, I think it's almost 8 or a little past 8 o'clock, so I'll just go right into this talk. I met Johan many years ago, and somehow he retained my email. And one fine day, he sent me an email and he asked me to join this forum. I think this is a great forum for education and spreading the work that we're all doing in our own different silos. So, tumor embolization topic, it's not a very extensive topic, especially for cerebrovascular physicians. It's a very kind of a debated subject, and there are many different opinions about it. But we still continue to do tumor embolization, and I want to share some of the Society of Neuro Interventional Surgeons guidelines. And then just dive into a couple of cases that we've done over the past few months. So that probably will be the agenda for the talk today. Hopefully we'll cover some of the questions. I think it's more interactive session, the way I view it, this topic as rather than there is not a lot of literature around it, but it's kind of more interactive. So let's go forward with slides. How do I do that? Okay, here it is. I have no financial disclosures related to the topic. Typically, for tumor embolization, type of tumors that we encounter as neurosurgeons is cranial tumors, spinal tumors, head and neck tumors. And endovascular embolization originally was described in 1970s. The primary aim or goal of embolization is, first of all, aid in successful surgical resection. The idea is that it will help control bleeding during surgery and therefore minimize surgical time and blood loss. It also will help visualization of anatomy, of course, because of the decreased blood loss hopefully or expectedly. And in some instances, it can be used as palliative treatment. There have been some instances or reports of palliative chemotherapy delivery with tumor embolization as well, with some benefit, but it's not there are no studies or no formal trials from the neuro surgery perspective. The type of head and neck tumors that we typically encounter for embolization are juvenile nasopharyngeal angiofibroma, hemangiopericytoma, glomus, or other type of paragangiomas. They're usually skull base and neck tumors, metastatic lesions, meningiomas, and hemangioblastomas. Meningiomas are kind of the most common and hotly debated topic. There are different views about embolization for meningioma, and some surgeons, when this all started, I remember a few years ago, there was a lot of talk about embolizing tumors, and then surgeons started to cut back because there is obviously associated complications related, which we'll talk in a minute. So first of all, when you see a patient that has a tumor, the first step obviously is a clinical evaluation, which is aided by a CT scan, MRI scan, MR angiography to assess the vasculature, and also look at the blood supply. Also, in addition to that, sometimes MR perfusion studies could also help to understand the vascularity of the tumor. So particularly when the angio architecture is composed of small vasculature. The blood supply is generally, we can make a little bit of a guess based on where the tumor is located. For example, paraganglioma, which is typically a skull base or head and neck type of tumor, usually is supplied by ascending pharyngeal artery. Carotid body tumors are generally external carotid artery. Meningiomas usually is blood supply, middle meningeal artery, anterior falcine arteries, a common artery for parasagittal meningiomas, and ethmoidal arteries for anterior skull base meningiomas. Posterior fossa can occasionally parasitize pica because it's a very tortuous vessel and usually is draped around the tumor, and it can parasitize and get blood supply from intracranial circulation. In general, meningiomas are expected not to have blood supply from intracranial circulation. So typically, it's a multidisciplinary approach, and when we look at the tumor from the cerebrovascular standpoint, when we discuss with our tumor surgeons, we the first thing is to define the goal of surgery. And in general, for most neuro-oncology, the goal of surgery is tumor resection. And the goal of embolization is to help the surgeon achieve that goal successfully, quickly, and with less blood loss. There are several different types of embolic materials used. First, very common one is glue. Then there is onyx. There is polyvinyl alcohol. And then there's microspheres. Microspheres are generally most commonly used. I'll just talk a little bit about that. And then there is also coil embolization. If there is a large parent artery, you can coil embolize that artery also. So let me just go a little bit into the technical details of all three of these. Or advantages and disadvantages. So glue is actually pretty good embolic agent. The problem with glue is it sets in very quickly. So nowadays when we do embolizations with glue, we usually dilute it significantly. We dilute it 1 to 10. And that allows us to get a deeper penetration. However, it still does not get the same penetration as microspheres or polyvinyl alcohol. Onyx is great. One of the problems that I've heard from surgeons is that when you, so onyx has a lot of penetration. It can penetrate into the tumor, it can penetrate into the vasculature, and even get up to the venous phases sometimes if you're patient and spend a lot of time. The one problem with onyx is that it's very rubbery and hard, and it actually makes the tumor hard. So in the beginning of my career, we were using onyx, and then we were hearing back from the surgeons that it was actually making surgery a little bit more difficult. And that's something we see in AVMs also. So we now tend to have cut back on onyx embolization for tumors. Polyvinyl alcohol and microspheres are kind of similar. The only difference is microsphere are available in many different sizes. And naturally, the smaller the size, more penetration you'll have into the tumor, and that's the goal. And the idea is to get rid of tumor blush. And a lot of times, if you use smaller particles, the disadvantage is that the intracranial and extracranial circulation anastomoses could be a problem, because when you block some of the blood vessels, the blood then starts to, or the vasculature then starts to divert to other and opens up other anastomotic channels that you may not see at the time of original angiography. Therefore, the size of choosing the size of microsphere is very critical when you're thinking about tumor embolization. Coil embolization is rarely done for tumor embolization. Sometimes it's done when there's a very large vessel, and as an adjunct to some other treatment, we do use coil embolization, but they are really hard, and we can cut them with micro scissors, but general concept is that we try to actually avoid it. Only in rare circumstances it's used. The route of embolization traditionally is trans-arterial route. There are newer techniques for percutaneous direct puncture, which we have done a few times, particularly for head and neck tumor, and it does work fairly well. And then there are combination of those two techniques. So we embolize a little bit of tumor percutaneous and then some of it transarterial. The clinical and radiographic efficacy, that's an important thing to understand. So again, it goes back to what's the goal of surgery and how do we actually define whether we have achieved that goal. And those things are important to understand. How do we further study it and develop more understanding of the effectiveness of this treatment or therapy? So there's not a lot, like I said, not a lot there in literature about tumor embolization. There's been several case series that we get most of the knowledge from, and then individual experiences. The literature support the efficacy of tumor embolization is to reduce the blood flow in order to reduce the blood loss during surgery. However, there are no randomized trials, so it's hard to assess based on individual experiences what the radiographic or clinical efficacy should be defined. So the consensus is that despite adding resources to the procedure, the cost effectiveness is still justifies continuing in selective cases. However, when reporting efficacy, the amount of tumor blush or staining, and then at the end of the procedure, how much we have gotten rid of it is the important radiographic marker for measure of success. Goal of embolization is also to reduce the blush, and most people suggest that if we reduce the blush by 80%, that would be considered a successful treatment. Of course, on the other end, at the time of surgery or after surgery, the operative time, overall blood loss, and need for transfusion are additional measures of efficacy. And then for palliative treatments, improvement in presenting symptoms and decrease in the size of lesion are also considered a measure of efficacy of embolization. Timing for surgery is also another controversial topic. There's been a lot of debate about it and different opinions and views. Excuse me. So the radiographic and clinical effects usually are transient. We all understand that. Once you embolize a vessel in a tumor, the tumor undergoes necrosis. There have been several small series that have kind of tried to outline the timeline for this necrosis. Usually, most people recommend that very early resection may have maybe potentially negative benefits. In my own practice, I probably have not seen that, but it's certainly something that's been debated and discussed. So if you do it before 24 hours, the idea is that there could be, it may not allow for necrosis to set in, and there potentially may be more blood loss than you would expect. So when you do microscopic studies of this tumor material, by day 7, you start seeing thrombus formation in the vessels and multinucleated giant cells, which is an indicator or marker of necrosis, which is what most surgeons are looking for to make the tumor softer so you can suck it out quickly and there's less blood loss. Some of the studies report that the softening of tumor allows early resection, even up to 9 days. However, after 7 days, there have been several studies that have shown that 30% of vessels start revascularizing. So tumors, particularly meningiomas, they're like, they're parasites. So they will keep on encroaching more vessels from the surrounding tissue. So it's a kind of similar concept in AVMs. If you embolize and you wait too long, the AVM will recruit other vessels, and other smaller vessels will then become larger contributors to the AVM. So a similar thing happens. So after 7 days, 30% of the vessels have been noticed to start revascularizing. So Society of Neuro-Interventional Surgeons do recommend that optimal time window is 1 to 8 days. Again, it's a typical recommendation from any neurosurgical society where they don't pinpoint because there is not a lot of literature. So they give a big window of opportunity, and then decisions could be made on individual level. If the tumors are larger, they do recommend that steroids should be given because necrosis obviously will cause edema and swelling. And sometimes edema and swelling can cause dramatic effects, particularly in large meningiomas. I'm sure we all have seen dramatic necrosis, swelling, even cerebral herniation, and you may have to go in and operate emergently, which obviously nobody wants to do. All of those things have been reported and have to be judged very carefully on an individual basis. How do we do the procedure? Anesthesia, that's again very institution and operator choice. We could do it under awake or conscious sedation, or do it under general anesthesia. The advantages and disadvantages are obviously very obvious for us as a vascular surgeon, because we do a lot of endovascular procedures awake. And the idea is that you can actually get a good neurologic exam while the patient is awake. So you can do provocative testing and actually see if the vessel would cause any deficits while you're embolizing. The provocative testing has a sensitivity of about 85 to 90%. But when you're doing with general anesthesia, particularly in cases where the vessels are very tortuous, patient may be very uncomfortable, or you may not be able to do it awake, then general anesthesia is also an alternative. Now for monitoring, when we do under general anesthesia, we typically use EEG, SSEP, and motor evoked potentials or intra-procedure monitoring, which does allow us some degree of comfort. But at the end of the day, a lot depends on the vascular anatomy, study of the vasculature prior to the procedure, and trying to develop an understanding of what would be the safest for the patient. Yet there are errors at times, again, based on the fact that there are a lot of microvasculature anastomoses between important intracranial structures and extracranial structures or vasculature that we may not actually see on angiography, and we may only see it when some of the vessels are embolized and the blood flow is diverted to those smaller vasculature. Complication, of course, every procedure has complications, and that's something that you have to weigh against when we are talking about tumor embolization. And some of the procedure-related complications, they're very minimal nowadays, particularly because we're doing a lot of procedures through radial approach, so the complication rate has significantly dropped. But puncture site complications such as groin hematoma, retroperitoneal hematoma, localized pain, infection, not really seen that, but certainly that's possible, or a reported complication. The main complications that we actually worry about are two. Number one is cranial neuropathy, again, because of the reasons that I have discussed already. Skin and mucosal necrosis, particularly for head and neck tumors, because if you do a large enough embolization of internal maxillary artery, eventually it will cause skin and mucosal necrosis. In general, most of that mucosa regenerates and comes back, but there are times when patients may have epistaxis, they may have pain. Sometimes tooth pain has been reported because there are small alveolar vasculatures that may get occluded and cause a lot of toothache, but usually it goes away after a couple of weeks. The second major thing that we are worried about is stroke and intracerebral hemorrhage that has been reported and has been seen for many different reasons. Technical reasons are obviously important because the vasculature is tortuous and the injury to the vasculature causes intracerebral hemorrhage. Stroke, we've already talked about. One of the things that I see rarely and less commonly is the intercerebral bleed or vessel perforation, because nowadays we have our wires and microcatheters. The quality of equipment that we have is so advanced that we can go very, very distal into the tumor and embolize without any such complications. We also have very compliant balloon embolization procedures. I'll show you one case in a bit that we did for a tumor with balloon embolization. So technology has improved significantly. Contrast induced nephropathy or other complications such as allergy, and then of course worse outcome, death, if there is a tumor that necroses very quickly. It can cause cerebral edema, mass effect, and herniation, and so forth. So anatomic considerations are very important. So I'm just going to touch briefly upon some of the more common and known ones. I won't go into too much detail in the interest of time. So one of the important important thing to remember is if you're doing external carotid artery embolization, those are very high flow vessels. The blood flow and the pulsatility, sometimes when you're embolizing, can cause the embolus material to migrate or herniate from the target vessel and go across the bifurcation into the internal carotid artery. So that's something very, very important. A lot of times nowadays, I typically do, if I'm doing a big embolization, I use a balloon to prevent that. But in external carotid artery, it is common. One of the problems is when you're embolizing the material, the quality of material, particularly if you're doing an awake patient is breathing or moving a little bit, the contrast opacification of the embolic material is not that great unless you're using glue. But if you're using glue, then you don't get a lot of deep penetration. So you have to weigh the risks and benefits of whatever you're doing based on the, again, goal of the surgery and what you're trying to achieve. Second more important one is ascending pharyngeal. So the anastomosis to ipsilateral vertebral artery at C3 is fairly common. It's sometimes seen during angiography. And then ascending pharyngeal also connects with the branches of infralateral trunk, which is a branch of cavernous carotid artery. So that's another connection that can cause intracranial embolization. And then ascending pharyngeal nerve is also very known or very notorious for causing cranial nerve deficits, particularly 9 and 10, which could be very devastating, and it can cause speech and swallowing difficulties. So that's why I'm very hesitant when I'm doing ascending pharyngeal, and I usually always do provocative testing. I've not seen that, but it has been reported, and it's one of the feared complications. So this is an angiogram where you can see this is an ascending pharyngeal artery paraganglioma, but because of the either tumor or because of the post-embolization effect, you can see that this is infralateral trunk, although we don't see intracranial circulation, but you can see a little hue of intracranial vasculature here. And then in this one, we're seeing anastomosis between the vertebral artery. So if you do ascending pharyngeal run and you notice this vessel, I'm not sure if you're able to see, but this vessel over on the right side, you can see a little bit of communication between the two vasculatures. Vertebral artery also communicate with the occipital artery at C1-2. This is a very, very common anastomosis. We see that very frequently, actually. That's something that you have to be very, very careful of when you're doing external carotid artery embolization. I typically visualize occipital artery individually to make sure, because I know that some of the embolic material will come back and has a potential to go into intracranial circulation. This is one of the anastomosis that keeps the vertebral artery alive in case of damage or dissection or vertebral origin disease. Middle meningeal artery and ophthalmic, this is one of the most feared complications of this procedure because we do a lot of middle meningeal artery embolizations. And there is always, the reported literature, it's probably less than 1%, but there is always a connection between middle meningeal artery and ophthalmic artery. And the central retinal artery is one of the, it's really a very, very tiny artery and a very critical artery. And all it takes is just a little puff of embolic material to reflux into, and most of the time you won't actually even see it on angiography. So that's why, so I've seen that, and that's why it's very critical to evaluate that beforehand. And even if you evaluate, I do a lot of these procedures awake, and I check their vision before and after, and pupillary dilatation. Part of the reason of this anastomosis is this small vessel, which comes out of the superior orbital fissure. It's called a recurrent meningeal artery or branch of ophthalmic artery, and it communicates with middle meningeal artery. I think I have a couple. Yeah, here's a angiogram picture showing external carotid injection, and you can see that this bayoneted structure here is the ophthalmic artery, and you can actually see it here as well on the intracranial run for confirmation. So in this individual, you are able to actually see the anastomosis, but a lot of times I will tell you that you won't even see it, and it can happen. Here, there is another connection at the level of foramen rotundum and Vidian canal between the external carotid artery and internal carotid artery. And this one is at Vidian canal at the petrous and laceral foramen lacerum, and between the ascending pharyngeal and the the artery of the Vidian canal. So I'll just show you a few cases that I've done over the past 4 or 5 months. And just to give you an idea of what we typically do and what's the application of these procedures. So case number 1 is a 65-year-old gentleman who presented with the progressive left-sided weakness, left arm and leg weakness and headaches. And he had this lesion little bit very close to the sagittal sinus, but still not attached or stuck to the sinus. And lesion had a lot of cysts in it. On T2, there were some flow voids, and we felt that this could be indication of increased vasculature, and therefore we ended up doing an angiogram. The original idea was not embolization, but we wanted to see if there was truly a vasculature, or if this is a Hemangioblastoma or something that may need embolization later on prior to surgery. So at the external carotid injection, you can see there's a large tortuous middle meningeal artery branch. And then you can see tumor blush. Not a very significant tumor blush, but nonetheless, we decided to embolize this, and embolization was performed with embospheres followed by NBCA. So this is one of the common techniques that we're using nowadays. So we do embospheres to cure the tumor blush, but we don't overdo it, because the reflux of embosphere is what causes a lot of problems. And also embospheres eventually wash away. So if you wait too long, then the vessels may open up again. And in order to prevent that, then we use glue at the parent vessel to embolize the parent vessel, so that there is no antegrade flow and the embospheres hopefully will not wash out. So here you can see another last run at the end of the procedure. STA, middle meningeal is embolized, and you can see a little shadow glue material in this vessel. The goal was to get into both of the branches of middle meningeal, which we were able to do. Surgery went really well. There was only 100 cc blood loss. Operative time was 2 hours. The tumor was necrosed by the time we got in there. And this is the post-op result. Very good outcome expected. Another case, a 19-year-old gentleman who presented with recurrent epistaxis. He had a nasopharyngeal tumor at an outside institution. Endoscopic biopsy was attempted without looking at the vasculature, and there was copious amount of bleeding, and then he was packed and sent to us. So prior to, he was, at the time he was stable. So prior to doing that, we did an angiogram. So this is an MRI, it's a large nasopharyngeal mass. Turned out to be a juvenile nasopharyngeal angiofibroma. Here you can see the maxillary artery run, and there's tumor blush, but it's not terrible. It doesn't look that bad, but obviously there's a lot of sinusoids and venous structures, and we know that this is going to. And the vessel itself is pretty big. This is almost the size of an internal carotid artery. It's about 2.5. So obviously there's a lot of blood flow going through this. So we decided to embolize it, and in the first instance, we placed the microcatheter in the middle meningeal artery, and you can see sphenopalatine artery. And the goal was not to overdo the embolization and just take care of the tumor blush and leave rest of the vasculature intact. So we don't. You can see these alveolar arteries here. These are the arteries if the embolic material goes into the teeth hurt. I've not seen anybody have their teeth fall off, but I've seen people come back and their teeth hurt and they complain, and then you just shake your head and just tell them to keep waiting and waiting, and eventually it goes. So this was the end result. Actually looks pretty good. And then our ENT colleagues took the patient to OR, and they started resecting, and within maybe about an hour or 2 hours of surgical resection, I got a phone call that patient is bleeding profusely and they can't control it, so I need to help them out. So we packed the patient's nose again and brought him down and to the IR suite. And this time, this is an AP view of the same vessel. This time because I knew already that there was going to be bleeding, I went in with a balloon, microcatheter or septal balloon, placed it in the middle meningeal artery, and just started embolizing with onyx. And you can see the onyx. So what had happened was that even though the tumor was not bleeding, but they got very close to this large internal maxillary artery and injured the artery, and that's where the bleeding was coming from. And in this view, you can see actually this is all the onyx extravasating from that puncture point in the middle meningeal artery. Anyhow, so we did that. Patient got blood transfusion. We watched him in the ICU for a couple of days, and then took him back to the ENT, took him back to the OR, and were able to resect the tumor, and he's doing fine. Now, this is another example of a tumor that we did a couple of months ago. This, excuse me, gentleman presented with a large renal met at T12 level and presented with progressive myelopathy, and one of our spine surgeons looked at it, and because renal mets are known to be very vascular, they requested for an evaluation and possible embolization. So, so we did that, and we did a segmental, a T12 segmental artery injection, and you can see tumor blush and abnormal vasculature in the tumor. This is the microcatheter angiogram of the same level. And then this one, we just did embosphere embolization. This is the end of the procedure. So after the procedure, patient was, I think the next day was taken to OR, and per report, the surgical resection was fairly reasonable. One of the problems with these deep, when you're not kind of doing corpectomy and there's a lot of tumor anterior and you're just doing posterior stabilization, fixation, and decompression, these tumors bleed a lot, and there is no way to stop them because you cannot go anterior to the thecal sac. So so for these type of reported vascular tumors, it is reasonable to embolize, and you can make the surgery a little bit more pleasant and just focus on the goal of decompression, because we're not curing this disease here. So the goal is decompression, so the patient can myelopathy is treated. So I think this was achieved really well in this case also. But you have to be very careful. We did several runs prior to, because at T12, particularly on the left side, there could be artery of Edenkovetz, and that could actually cause paralysis by itself, or paraplegia by itself. So again, the idea is that you have to know what the vasculature is, the vascular anatomy, and what are the structures that could be at risk for any level of embolization or any anatomic segment that we're doing. All right, with that, I would say thank you for giving me this opportunity. It's almost 8:33, so it's 30 minutes. So I'm open for questions if you have any.
Thank you so much, Dr. Siddiq, for an excellent talk. And so we can start. We have Dr. Juma also. I think he has joined us. He's here. I would like to ask his comments. And if Dr. Juma.
Yeah, sure. Thanks, Hassan. So, good afternoon, and Farhan, thank you for sharing your very interesting talk. Although we have a long history of getting patients embolized preoperatively, obviously the kind of range and scale of things that you do is not common in neurosurgical practice. I'm thinking of the paragangiomas and the globus tumors and things like that. We just don't see them anymore. So we're still stuck with that group of patients with meningiomas, skull-based convexity, and to a certain extent the hemangioblastomas. So you're right about the fact that one can discuss it both ways. And that comes down to individuals' experiences. I'd like you to just speak a little more to the issue of hemangioblastomas, because that we've had some experience with at Afghan Hospital and in Karachi, but not obviously very aggressive embolizations. Largely because, unlike meningiomas, the blood supply is right from the intracranial circulation. And so that puts limitations, but in the hands of somebody who's experienced like Farhan, it may actually be extremely helpful. So I'd be very interested to hear just a little more about hemangioblastomas.
Yeah, so hemangioblastomas are a wild card. They are very vascular tumors. I consider them as AVMs or AVM tumors. They can parasitize and get blood supply from any vessel or vasculature that you can imagine, or it's around them. So generally, we try to do super selective embolizations on these tumors, and there have been a few instances where I've actually done anterior cerebral artery branch embolizations. With our new catheter devices that we have available, you can actually get into very, very small vessels. I don't have, unfortunately, don't have those pictures available, but you can actually get into a vessel size of 0.5 millimeter or even less, and embolize the tumors very safely. But we typically do that with provocative testing and EEG and motor evoked potentials. Also, you have to look at the anatomy, where the location is. Is it before the motor strip, after the motor strip? So I've done a few of those. In general, I typically like to reserve embolization for any extracranial vasculature, or external carotid derived vasculature, such as middle meningeal artery or so forth, if it's a skull base. But it has to be studied. I mean, all of these tumors are so variable, and it has to be studied based on the location. There are times that you can do it. The biggest problem that I've encountered is if there is a large blood supply from ophthalmic artery and ethmoidal arteries, and you look at it and you feel like you can do it, but those have very high risk of complication, because even if the vessel is big and it goes into spasm, it can cause blindness, whether an embolic material got into it or not, and that's a pretty bad complication. So so in short, the answer is that I have done it, but it's not very common that you will find a recipient that you can safely do. But if you find one, then yes, it can aid into your surgery.
And Farhan, very quickly, a posterior fossa hemangioblastomas. Any experience with that?
I have not done embolization on posterior fossa hemangiomas, because they a lot of times derive their vasculature from pica, and that's what I do in my and those vessels are so small, they are so intense. You can't get into those. In fact, I just had one of my colleague presented to me, and we did an embolization. Sorry, we did an angiogram, and we looked at it, and it would look like the entire pica was a tumor blush. And at the end of the surgery, he ended up taking the whole pica, which I could have done with embolization too. But I think in surgery, you may have better control and have a better decision-making capability than angiography. So posterior fossa is a more difficult thing to undertake, because there's a lot of very small vessels. For example, anterior spinal artery, you don't actually even see it in most angiography. And any 100 to 150 micron size embosphere goes into it, it's gone. So I typically, if I have to do embolization of posterior fossa, I typically try not to use embospheres and just do parent artery embolization with a very small amount of glue or onyx. But for a hemangioblastoma, I have not been able to. I've seen maybe 3 or 4 angiograms over the last maybe year and a half or 2 years, but none of them were embolizable.
Farhan, thank you for your time. Thank you very much indeed. I enjoyed that.
Thank you.
Dr.
So Farhan, I have a little experience with hemangioblastomas in my practice as well as during fellowship. So from what I remember, I mean, you're absolutely right that these are very rare tumors, and so you may find 1 or 2 a year. During fellowship, we never even attempted embolization of intracranial hemangioblastomas. But for spinal hemangioblastoma, which are even rarer, we would always at least do an angiogram and try and do embolization. Can you comment on what blood supply may be involved in spinal hemangioblastomas, and why they might be more amenable to embolization, if you agree with that?
Yeah, well, I have not done it, but I think from people that I've talked to, it's usually the segmental blood supply, and there is for the segmental blood supply, those vessels are actually outside the spinal canal. The only thing you need to watch out for is artery of Adam-Kivetz. Now, all of those arteries have connections, because there are radicular arteries that actually then supplement Adam-Kivetz, and generally it's on the left side between segment 7 to 11. So I typically always inject. I see an arterioverum cuvette coming from an opposite side or whichever side, and then I go to the tumor vessel. I haven't done any hemangioblastomas of spine, but that's kind of the approach. And because they are segmental arteries, the actual artery is outside the spinal canal. So that's why you can actually embolize them relatively safely, but you still have to choose larger size particles, because smaller particles will still penetrate radicular arteries and go into smaller vessels. And again, do a provocative testing. We do it under general anesthesia, because spinal angiograms are painful, because I mean, they're long. They're not painful because of the pain associated with the procedure, but they're long and it's hard to lay down on a table. So we generally do it under anesthesia, and we always check neuromonitoring for those.
Okay, wonderful. I also had a follow-up question. So a few years back, I think when I was in my fellowship or residency, there was a phase 1 trial. I think you touched on a little bit, but that phase 1 trial was coming out of New York, and they were trying to open the blood-brain barrier and directly allow some chemotherapeutic agents to be delivered intracranially, and that was within the context of glioblastoma. And I never heard if that went forward. I know that people don't do it, but what's your take on that? Why didn't that technique or that mode of delivery catch on?
So we were part of that trial at University of Minnesota, and or registry actually. We were part of the registry. No, I think it's not a trial really, but so I have some experience of doing those procedures. One of the biggest issue was assessing for efficacy was very difficult, because after the blood-brain barrier disruption, a lot of patients were very, very sick, and they would have seizures. You would have to give them steroids, keep them in hospital and ICU. They would have neurologic decline or deficit and edema. So I remember that very clearly, and I think the overall impression that I had was, again, this is not reported, but overall impression that I had was that it really didn't increase. It was mostly utilized for grade 3 tumors, or anaplastic gliomas. But it really didn't increase any of the life expectancy that we were hoping for. So I think that's my impression. And what it did was that it made follow-up angiography, or imaging more difficult to assess whether it was tumor or edema, blood-brain barrier disruption related contrast enhancement. So
what were you using? Were you using Avastin, or what were you using?
I don't remember. We did use Avastin. I don't remember what other agents were used. But Avastin was certainly one of them.
Okay. Okay, wonderful. I was told that we have listeners from Philippines and Malaysia as well. So welcome. This is wonderful. I think Essen, if you want to filter some questions, I think there are questions coming in.
So we can take questions, but I would like to ask Dr. Inam if he has some comments, and then we can go absolutely. To the questions from our participants.
No, thank you, Hassan. Let's hear from our colleagues from Malaysia and Indonesia. And
okay, so we have a question here in the chat box by Dr. Abdul Kareem, and he is saying, kindly discuss on the following: minimum and maximum intraoperative estimated blood loss. I think he is asking a couple of things in this question. Radioembolization combines embolization with radiation therapy by radioactive isotope. Kindly share your experience on direct tumor puncture as well. So sorry if you would.
So direct tumor. So I'll start with the bottom one, because that's something I know a little bit about. So direct tumor embolization I've done several times for paragangliomas. They usually ENT or skull base or head and neck surgeons usually bring those cases on, and it's actually a very safe technique. I typically use ultrasound. I do it under general anesthesia. I typically use ultrasound to find the tumor, and then under ultrasound guidance, penetrate the tumor with a spinal needle, and then do a it's not really an angiogram, but contrast injection, and that can show the vasculature. Usually there are venous sinusoids, and then you can directly inject them with either onyx or glue. Typically glue is used, very dilute, 1 to 10 glue, so it can penetrate into the tumor. And then we do follow-up angiography of external carotid artery to see how much penetration or embolization. Our goal again is close to about 70 to 80%, and it makes surgery fairly reasonable for the operator because it reduces blood loss. So that's something that we have done. I don't remember if I've done for any other tumor. I've done direct puncture embolizations for other things, but not tumor in the cranial setup. The first part of the question was radiation. I don't have any experience, or radiation embolization. Was that radio material? I don't have any experience with that. I have not done that in neurosurgical world. I've not done that. There are other peripheral tumors that have been treated with that approach, but not so far for neurosurgery.
Okay, and I think he also asked about the blood loss, if you want to comment on that.
So if you're talking about blood loss during the procedure, that's minimal because for most angiography procedures. But if you're talking about the blood loss after as a result in surgery, if your embolization is successful, the blood loss ideally should be fairly minimal, and you can actually, if you're operating yourself, or if you have your colleague operating, you can actually at the end of embolization go over the rest of the angiogram and see where the blood supply is coming and anticipate that during surgery and attack it right away. And the 1 or 2 tumors that I showed you, the surgery was just so pleasant because it was, in fact, really made the procedure a lot more fun than typically it does. But again, I would say that embolization is not for surgeons. Embolization is an adjunct. If it can be done safely, great. But if you have any suspicion, don't do it because it's another procedure and it adds to morbidity of the entire disease. And I have one patient who we embolized, and he, the tumor was very large, and the surgery went really well. But as a result of embolization, he lost his half of his vision. So now it's not, we can't justify it. So as surgeons, we have to be able to control bleeding, but there are certain tumors where bleeding has its consequences too. So you have to, Hemangioblastomas or a very vascular meningioma. But generally for skull-based meningiomas, my approach is that you can get to the vasculature very early on and you can actually devascularize the tumor. And very rarely they parasitize unless they are very large. So very rarely they parasitize intracranial circulation. Sometimes they do, but that can be relatively easily picked off. And so for skull-based meningiomas, I rarely even entertain the idea of doing an angiogram because that's something that a skull-based surgeon should be able to do. It's mostly for the other, cortical meningiomas or larger meningiomas, which have either vasculature or some suggestion of a large vascular blood supply.
Thank you. Usman, you want to ask something? Please,
yes,
go ahead.
Thank you, Dr. Siddiq, for an absolutely amazing session. I'm Usman. I'm from the AQ class of 2020, and I'm currently working as a research associate with Dr. Inam. My question is that has the role of intra-arterial MR perfusion gained any significant ground when we are deciding whether to go for pre-operative embolization or not?
So occasionally we do MR perfusion to see the vasculature of the tumor. I have not very commonly done it, but occasionally done it. In our practice, tumor embolization is not a very common thing. We really approach most tumors. So we only do tumors where we have some suspicion that there is a high vasculature, suspicion that it could be a hemangioblastoma, suspicion that there is a large vessel or flow void. So only those tumors we do. So then at times we do MR perfusion. But like I said, we don't routinely do it. This is an adjunct for some tumors. It should not be, I don't consider that as a part of evaluation for every tumor. It's only some tumors. And then there are some times where you get into a situation where
he's asking you.
Sorry, what?
Dr. Inam, we cannot hear you, sir.
I think Dr. Nam is frozen. So while he, oh, here, he's back.
So is that what you were asking, Khalid? Osman Khalid? Yeah. Are you asking about tumor MR perfusion?
So yes, sir. I was asking about the intra-arterial.
Yeah. I haven't done that routinely. I have not a lot of experience.
Thank you,
So,
sir.
I think Dr. Inam wanted to say something, but then I think we lost him. And then, okay, so we have another question here from Dr.
I was
Sir, okay. Yeah, so do you have experience in pre-op embolization in choroid plexus carcinoma in infants?
No.
Okay. We have, okay, sir. I think Dr. Inam is back. Sir, Dr. Athar. Sorry.
No, I was just going to make a comment. Whoa. Usman, the reason Usman is asking you, Farhan, is because he wants to start a study on that. So I'm just guessing that. So he's trying to get some idea from you to start a study on MR perfusion pre-op, and then correlating that with, right, Usman? Is that what you were thinking, Usman? Yeah, see, I knew that.
Yeah, no, I think, I mean, for the study purpose, yeah, these are all great questions. I think there's a lot that we are learning about the new MR techniques and MR angiography and perfusion, which is really helpful. So I think.
So Farhan, I have a question. It's not actually about the tumors directly, but we do use radiosurgery for tumors as well. And there is a mixed data on the AVM, radiosurgery and embolization. So, and there are mixed opinions also. There are some data that suggests actually using embolization would enhance the efficacy of radiosurgery for AVM, and there are some studies that suggest actually it blocks the radiation and it hampers. What are your thoughts on I mean, if you can include AVM also? I know it's a neuro-oncology session.
So AVM. So again, one of the largest problem is we don't have a good randomized study, or it's very hard to do a randomized study because every AVM is so individual that it's just you can't generalize them. My approach with AVM is from what I have heard from literature is that, you know, in about 5 to 7 years ago, there was a lot of talk that onyx embolization actually reduces the effect of radiosurgery. But that has been challenged, and actually there was recently a study that actually showed that overall embolization rates were pretty similar, keeping in mind that onyx embolization was not penetrating the majority of the AVM. So the majority of the nidus of the AVM was still visible to be able to embolize. But the problem is if you have too much onyx and there's not a lot of nidus, most people think that that could be a problem because you may not be targeting the right area that needs to be treated with radiosurgery. So I think that there are different views about it. So if I have, let's say, for example, if I have an AVM that has very high flow and patient has headaches for that reason, and I want to not resect it because it's either deep or whatever the reasons are, very close to eloquent cortex, then I would embolize a large feeder, try to avoid deep penetration into the nidus, and then do radiosurgery. I haven't, again, not seen a lot of follow-ups to say that in my practice, what is the cure rate, but the reported cure rate is not vastly different when you use embolization. For that very purpose, a lot of centers are actually using glue embolization because the idea is maybe onyx has some kind of radio-resistant properties. Again, these are all speculations. I don't think anybody knows the answer. So I think my view is that individually evaluate every patient and define the goal. If the goal of surgery or goal of treatment of this AVM is removal, then obviously embolization with surgery is the best idea. But if it's an unruptured AVM and it's deep location and a highly functional individual, and you're thinking that patient may have, in fact, I just had this discussion with a patient yesterday that I was thinking about surgery, but the AVM is in the eloquent cortex, actually just right below the motor strip, and he's a very highly functional individual. So we ended up deciding to, we had done an embolization before for purpose of planning for surgery, but in the end we decided to do radiotherapy. So we'll see what the results are. So I don't think that holds a lot of value. I think the problem is that when you have a lot of nidus penetration, you can't actually see the nidus. You may not be delivering the right dose. So you can still embolize a parent vessel, reduce the flow, and then doing radio surgery if patient has symptoms. If patient has no symptoms, straight away radiosurgery is fine. You don't have to actually embolize anything. But there are patients who will come in, they have pounding headaches, and you suspect that this is because of the high flow, then those are great.
Thank you. Sorry, Umar, it took it away from tumor to AVM. Okay.
That's all right. Farhan, I have a follow-up question. So you mentioned that there's a broad range in the time period after embolization of an intracranial supratentorial meningioma. You quoted 1 to 8 days. Can you comment on whether this time period is shortened when you're talking about spinal metastases or spinal tumors that are embolized, or can you still have almost a week between embolization and resection?
You know, I'm generally a little bit nervous. I don't wait for a week. I usually, because I know that tumor, you embolize the tumor, it's going to swell because it's going to be
right.
And if you're spinal, you're doing it. If you're doing it for myelopathy, I don't wait for a week. I usually embolize, and within 24 hours, I operate. Typically, the way our schedule works is that we do embolization in the morning of day 1, and then the next morning patient is in OR. So we give about 24 hours. I try not to do more than that because it's going to necrose. There's going to be bleeding in it. It's going to swell. For intracranials, also pretty much similar. I know that the range, so there are this whole range is based on some of the studies and maybe some of the operators that I have never met, but they usually wait for about a week or so for surgery because they feel that the necrosis is maximum by day 4 or 5. So if you look at the microscopic literature, it makes sense because there is more breakdown. There is time for phagocytosis to occur, time for macrophage infiltration to occur. So yes, by day 4, I mean, it's the same concept as an infarct. So you're basically causing a tumor infarct. So by day 3 to 4 is where you see maximum activity in an infarct as well. But again, the idea with neuroscience is that there is really no room for swelling because when the patients present, they already are at a maximum point of decompensation. So any more decompensation is actually very harmful. So 48 hours is probably reasonable. 48 hours or somewhere close to that. I usually don't wait more than that. Maybe it's just my own bias, or it's the people that I have worked with or trained with, and that's it's their bias that's just kind of going through me. But I just fear that if you wait too long, the edema and swelling could cause irreversible damage.
No, I completely agree with you. This is exactly what I do as well. I wanted you to highlight this because we have a lot of trainees in our session as well. So I think some key take-home points are important. One is this, and the other one that I think you mentioned as well was, is embolization necessary for skull-based tumor or skull-based meningiomas? And again, I agree with you that you can very early on devascularize those tumors, and most of those meningiomas are fed by ethmoidals, and so there's no really point of embolizing those unless you want to study the angioanatomy, how close the ACAs or MCAs are pushed or displaced. But there's no role for embolization for skull-based tumors as well. So just some take-home messages for trainees.
Yeah, the ethmoidal feeders are actually dangerous. They might persuade you. You do an angiography and there is a big ophthalmic artery, nice looking as ethmoid feeders. Never go for it. Just that's a big no-no because Ophthalmic artery is very, very sensitive. You put a wire and microcatheter in it, it's going to spasm, and there's nothing you can do. And central retinal artery is one of the tiniest arteries. And I've seen it. I've seen a couple of times where people have been blinded by adventurous attempts, and you actually don't even embolize and patient can still become blind by going into ophthalmic artery.
Thank you.
Thank you. So Dr. Chauhan, it's already 7 p.m. here and I think 9 there in US. If you want, we can ask maybe Dr. Farhan Mirza is with us to share his comments, or what do you suggest? Or we can just...
Yeah, fantastic. Yeah, let's...
I always like asking
if
Dr.
there are
Farhan.
more questions, I think we should entertain. If there are a couple more questions.
Yeah. Dr. Atri, you're mute, sir. Sorry.
While Dr. Farhan comes on, I just have a quick question. Dr. Dharmendra, where are you from, Dr. Dharmendra? I just was curious a little bit.
Dr. Dharmendra asked a question.
Really, I just, it's interesting that, there are a lot of international audience that's coming in, as Dr. Chauhan mentioned earlier. Which is just wonderful. I mean, Umar, through this, you're reaching out to so many people beyond Pakistan. So that's just a wonderful thing. And I think we need to somehow encourage that and reach out to more people, because there are no boundaries now, no geographical boundaries between my best friend and my mentor in the Society of Neuro-Oncology is actually my Indian friend Rakesh Jalali, and I have declared it on international forum that you are my role model, Rakesh. So talk about India, Pakistan, right?
Right.
We have Dr. Mirza with us, Dr. Farhan.
Okay, Farhan.
Thank you, Hassan, Dr. Dr. Siddiq. We have communicated previously, and I actually pulled up that email from December 2011. That's the one time we communicated.
Whoa.
Yeah.
Well, wait a minute. Are you going to embarrass him, or is it something good?
No.
We can mute you off, Farhan.
No, it was me asking him for guidance about training and all that at that time. But
Farhan,
it's
can you
amazing
introduce yourself for everybody?
Sure.
Just so everybody knows.
Farhan Mirza. I'm a graduate of AKU, and I finished my neurosurgery residency at University of Kentucky and fellowship in Montreal, Canada at the Montreal Neurological Institute. My practice is epilepsy surgery and brain tumors, and I'm faculty at University of Kentucky now. So great talk, Dr. Siddiq. In my personal experience, we, as you said, it's not common for us to use embolization. I can't remember last time when we used embo for meningioma specifically. For big nasopharyngeal carcinomas and such, yeah, I think that's where it's quite helpful. But great talk. I enjoyed it. Enjoyed listening to the discussion afterwards as well.
Yeah.
Thank you.
Yeah, you're right. So I think so as an academic center, we always tend to do a little more and try to push the boundaries. So we do occasional embolization here and there, but you're right. I mean, I think the one case that I showed you earlier, the middle meningeal artery, did we have to do it for surgery? Probably not, but what's the advantage? Well, the surgery was quicker. The residents ended up doing the entire case. I just, I just basically supervised it. But so it does make things a little bit simpler, but is it necessary? It's probably in a lot of cases not, but in some cases it is. So you just have to evaluate the utility. And again, just like any other technology and technique, if you try to overdo it, you're going to eventually hurt people. So I think that's the take-home message from all of this.
Right.
Dr. Chauhan, with your permission, so can we end this session at this point?
Yeah, absolutely. Thank you so much, Dr. Siddiq, for spending your Saturday morning with us, even though you are post-call, as you told me, and you're still in scrubs. So we value a lot your input, and I'm gonna hold on to your name and contact and call you back for another session. As Dr. Inam has previously mentioned, that we'll be starting a more general series on non-oncological topics as well. And so your expertise in vascular neurosurgery will come in handy for those sessions as well.
Thank you. Yes, sure.
Dr. Inam, you want to add something? So, any final remarks?
Can I add anything after Umar? No, sorry, I can't.
All right. Okay. Thank you all. So that was an excellent, wonderful session. Thank you, Dr. Siddiq. Thank you so much for joining us today. We were honored and we really enjoyed your session. Thank you so much.
Thank you. Thank you.
Thank you all.
Thank you so much.
See you soon.